Okay, everybody, welcome back again, another episode. So, I've been meaning for a while now to do an interview with somebody who could sort of speak on the first-hand experience of working as a practising psychiatrist. But I was worried that going down that route might be either a bit dry if we just sort of spoke about like the technical aspects of being a psychiatrist, or it'd just be asking somebody to recount loads of like a string of anecdotes about other people, which would feel a bit rude. So I kind of put it on the back burner. But my guest today has an interesting perspective on all this, in that she is both a career psychiatrist and she's a service user herself, having suffered with bouts of depression for almost her entire life, I think since being a teenager. So my guest today is Linda Gask. Linda is an emerita professor of primary care psychiatry at the University of Manchester and a retired psychiatrist with over 30 years of experience working in the NHS. She's the director and co-founder of two social enterprises, including Storm, which provides training in suicide prevention, and 6 Degrees, providing primary care mental health services to people in Salford in Greater Manchester. Linda has worked as an advisor to the World Health Organization, served on the board of the World Psychiatric Association, and in 2010 she was awarded an honorary fellowship at the Royal College of General Practitioners in recognition of her teaching in primary care mental health. She is the author of more than 180 published articles and a number of books, including A Short Introduction to Psychiatry and the book which forms the inspiration for today's conversation, which is The Other Side of Silence, a psychiatrist's memoir of depression. That's pretty much all we've got time for this week, folks. Interesting career, Linda. Welcome to the podcast. Thank you for joining me.
Thank you. Thank you for inviting me.
Okay, so I suppose we just sort of dive straight into this. What I usually do is I usually ask people to sort of give us a brief biography, and their interest in their profession, whether it's psychiatry, psychology, whatever it is. But with yours, I suppose it's a bit more of a chicken and egg question. So I'm interested in which came first, the depression and the mental health struggles, or the psychiatry? So let's start there.
Well, I think the mental health struggles came first, but I wasn't really aware of what they were. I don't think you are necessarily aware of what's wrong with you when you're young. You just know that things aren't right and that you can't cope, and you don't recognize that as being mental health struggles. You just kind of struggling to get on with life. And that's what happened to me when I was a teenager, when I had really awful anxiety when I was doing exams. And then when I went to university, I got extremely anxious. But while I was at university, I got interested in psychiatry. And I remember going out to visit, when I was doing pediatrics, I had to go out and visit a family at home, where the little boy was going to be referred into the clinic, and I had to go out and meet the family and talk to them and try and find out what had been happening and what the problems were. And the child psychologist said, you did pretty well with that. Have you ever thought of doing psychiatry? And I'd never thought of it till then. I just realized that I could kind of identify and understand with the kind of problems that the family were having. Maybe that was because, my own family had some problems. I don't know. But it clicked. And when I did psychiatry as a medical student, I just kind of felt at home. I felt more at home with people on the psychiatric unit than I did with anyone else, really. And I really enjoyed talking to people. I enjoyed listening to their stories, finding out what had happened.
Yeah, was it as you were learning about psychiatry and doing your degree, was there a level of sort of self-analysis maybe kicked in, and that journey when you started learning about psychiatry, did that sort of, when you say, Did it make things click into place from beforehand? You started to understand yourself as well.
Yeah, you start to think about yourself. I mean, when you're talking to people about their experiences and about their life, you can't help it. It makes you reflect more on what's your story because, my brother had quite serious mental health problems. And I remember first looking that up in the textbook and thinking, well, no one's ever mentioned that, but that makes sense to me, and starting to understand quite a bit more about my not very easy family. And lots of the people that I met in psychiatry had similar experiences. So you start to think, I can kind of make more sense of how I am the person that I am.
Did you have any sort of iatrogenic effects from this? I suppose it could go one of two ways. That for me, when I received a diagnosis of agoraphobia, it was a bit of a double-edged sword for me. It was a bit of a self-fulfilling prophecy. I started to look into it. I started to read into it. They sometimes say that doctors make the worst patients.
They do.
Yeah,
I agree with that.
Yeah, and I started to read into agoraphobia and anxiety, and then symptoms and issues started to arise that hadn't been there before, but almost as a direct result of reading into it. But at the same time, learning about it gave me a sense of understanding and a sense of direction as well. Was that the case for you? And was it maybe one more than the other?
I understand what you're saying, because one of the things that certainly happens with medical students is that almost every subject that you study, you start to suffer from it. Right. I remember going and seeing the GP and saying, I've got a lump in my neck. And he said, oh, what have you been doing recently? And that's how it is. You do, if you're an anxious person, you do learn about things and you worry about them. But I think it was less that with my mood. I think I was actually really worried about getting those experiences because I came from a family where my brother had some mental health problems, and I was worried about becoming like him and trying to pretend that I wasn't really. So there was more of a sort of fending it off rather than saying, oh yeah, that's me.
Okay, so what I'm interested in here is this sort of, this maybe, what's the word? Is it like a dichotomous relationship or dichotomous experience that you're going to have of being a psychiatrist and helping treat people, but needing help yourself and suffering with things yourself. So I guess my first question is, what would be some of the, we'll start with the benefits. I'm interested in what some of the benefits are of being a psychiatrist with personal experience of this. And one of the reasons I'm asking this is, I think, especially from maybe a service user perspective, you kind of, well, I don't know, actually, I'm making an assumption here. For me, anyway, I quite like the idea of a therapist that's maybe, they've not made, they know about this, but there's a distance from it. They can't relate to it too much. It's almost like if I'm going to sit down with a therapist, I don't want them to be like a nervous wreck like me. I need someone who feels grounded and abstracted from it. But I guess some people would want the exact opposite of that as well. So I'm just wondering what start with the benefits of coming at it from that perspective for you.
Well, I think you're absolutely right. When you see a therapist, you want that person to be there for you. You want them to be grounded. You don't want them to be kind of making demands on you or looking anxious or suddenly getting distressed by things that you're saying. So you're absolutely right. And at the times when I've been unwell during my career, I have not worked. I've had to take time off because you can't be there for other people. You can't provide that kind of grounded presence for people when you're feeling very, very anxious or when you're feeling very down. But I think what I certainly found was that I could understand what it was like to walk in that room, not know the person you were going to talk to, and have to come out and say things that you'd never said to a stranger before. Or in my case, I'd never said to people that I kind of knew as colleagues, because, I knew the people that I was seeing, and have to kind of say very personal things to someone you've never met before. And that it's a very odd situation talking to a therapist in a room who isn't a friend about really personal things, and how you kind of feel like there's a danger that you're being judged by the other person as being somehow, lacking in something, and all those ideas and worries you have about yourself as being weak and feeble and unworthy, that you're worried that the other person is going to be thinking the same thing, and you're really taking a real risk with people when you bear those very personal things about yourself. And I know what that feels like, and I think that was helpful for me. I think that was helpful for the patients that I saw, for the service users who came to see me, because I had that kind of insight. Once or twice later on in my career, people did say to me, have you been depressed because of the questions you're asking, because of the way you're putting those questions? And I said, yes, I have. Once or twice I'd had absences from work, and people notice when you're absent. They worry about you. They worry if you're going to come back. And, but I would say, but we're not, if they then wanted to ask me more, I'd say, well, really, today we're here for you, and it isn't about finding out about me. And I've heard of situations where therapists have clearly not been well when they've been seeing clients, and that is really not a good position to be in with people. You're not providing a professional care for people. They've got to know that you are there for them and strong enough. And one of my own, one of the psychotherapists I saw when I needed treatment, looking back, it was clear that he really wasn't very well at the time as he was seeing me. He wasn't coping with life. And it was quite scary for me, thinking that he wasn't completely, wondering what was going to happen to him.
Do you think, what would your response be to someone that was sort of cynical about the idea of a therapist having not just at the level of relatability, but someone cynical might say, well, I don't want to see a therapist that struggles with depression or anxiety or whatever, especially if it's on an ongoing basis, because surely if they struggle with it, then how are they equipped to help me? Because obviously they can't sort out their own problems to an extent. What would your response be to that?
I wouldn't have any problem if that was what the person was saying. I wasn't open about my mental health problems while I was working. I didn't be public about them until after I retired, partly for that reason that, you don't want, I think, for the purposes of kind of just ordinary privacy, you don't want people to know all of this kind of public things about you. But if a person was saying that, that wouldn't particularly bother me. I think I might say to them, but that kind of points up that they're human too, and that we're all human beings and we all experience the same things. But I don't think you should ever kind of force that with someone. I think it is about people, at least at first, finding someone that they can relate to. And that's often a problem in our mental health services, because there isn't a lot of choice in the NHS. You get whoever you're referred to, and that can be very difficult for some people. They just don't fit, that fit between the person you're seeing and you is really important. I think it's a very big part of why people recover.
What if you took that sort of criticism one step further though, and said that if someone that's purporting to help people, and if they're not in some way, if this profession, being a psychotherapist or a psychiatrist, doesn't in any way sort of inoculate you, because like you said, everybody's human, everybody goes through this, but I suppose one criticism might be, well, surely trained therapists should be less susceptible to it, and that just by virtue of not just being human and having those human experiences, but by virtue of not being less susceptible to them, that maybe discounts the qualification to treat other people.
It doesn't. I don't think it works like that. I mean, it's like, I remember I used to have to explain. I've known people in my life who said, "Oh, you're a psychiatrist, then you should understand how the brain works. So how does that mean that you get depressed?" You know, and you say, "Well, I might know these things, but that doesn't mean that emotionally I'm any different from anyone else. I might understand and know a lot of things." I mean, I can think of times in the past when I've written wonderful pieces on how to lead a mentally healthy life and all the things you're supposed to do, and then actually living that kind of life can be really much harder. That we all struggle with those things. And I think sometimes I would prefer to see someone who understood the difference between knowing something and actually being able to put it into practice. That's the knowledge of how to live our lives and how to cope with stresses is all very well, but actually being able to, how hard it can be sometimes to actually deal with those things in everyday life is it's stressful and difficult, and I know what that feels like because I've had to struggle with a lot of those things.
Yeah, I guess there's something to be said for like perspective as well, in the sense that, you know, because the therapist is able to abstract from the experience of the client, it offers a different perspective, whereas the therapist is inextricably linked to their own emotional experience as well. It's not possible to abstract from your own emotional experience in the same way that it is from somebody else's, maybe.
No, but you do learn. One of the things you do learn when you have supervision, and that's why supervision is so important. And certainly during the years I did a lot of psychotherapy, one of the things about supervision is you go and talk through things with your supervisor, and that helps you to sort out how much of what I'm feeling is to do with what the client is telling me and what's happening in their lives, and how much of that can help me understand them, and also how to distinguish that from my own feelings and my own worries and my own anxieties. And that's why supervision is so essential. You should never see a therapist who isn't getting good supervision, because they have that time to reflect on what they're hearing about you and trying to understand, trying to think things through. That time for reflection is so important. And a lot of doctors, I mean, as a psychiatrist, I didn't get that supervision, because when you're qualified, it's assumed that you don't need supervision. And so I would always make sure I had that. I had a colleague who I would talk over those things with. Being with people who are distressed, depressed, paranoid, really troubled by their lives has an impact on you. And for me, it was just absolutely essential to have someone I could go into their room, have a cup of coffee, and we could sit and we could talk through and help me try and understand, you know, how you differentiate your own worries and concerns from the importance of the things that the person's telling you. And that's what supervision's about. So it is, I think my experience helped me with that and helped me to see the importance of that. But you're always trying to, one of the things about my profession is, I think that certainly when I worked in psychotherapy, was that you can always spend an awful lot of time reflecting on looking at things from different points of view. You can get your head in quite a mess if you're not careful. You've got to sort of step back and as you say, take a broader perspective.
The other thing I'm interested in how it's maybe affected you is at maybe a professional level. I'm wondering if there is maybe maybe stigma within the profession, like between psychiatrists. And one of the reasons I ask that is I believe, I might be wrong about this, but I believe that psychiatrists and dentists, there was another couple of professions, are amongst the professions that have got like the highest rates of depression and suicide, I think.
That's right. It's amongst medics, it's anaesthetists, psychiatrists, vets are also quite high, and dentists have got a high suicide rate too. There is a stigma. There's no doubt about that. I think that it's
Sorry,
not.
Linda, what's the nature of that stigma?
The stigma is that part of it's to do with not just being a psychiatrist, but to do with being a doctor. There is this thing in medicine about being tough and about being able to, you do this training and it's really tough, and it's almost boastful at times about how hard you've worked and how many nights you've done and all of that. And it's to get through it, you have to be pretty tough. But people kind of, I think, confuse this idea of being strong and being tough. They think that being strong is pushing all your emotions away, never admitting that you need help, being able to tackle anything, being quite macho. Whereas I think being strong is actually the opposite. It's being able to say, this really affected me and I really needed some help with this. And, there are times it's hard. And in medicine, that isn't something that people find easy the world over. And then when you add psychiatry into that, it's not easy. I think, even though I know a lot of colleagues have experienced problems with their mood, and I know a lot of people within mental health have family histories where they've grown up with people with mental health problems, I still think it's really not easy to admit that you've got mental health problems. Partly it's to do with that being tough, but I think there is still very much, and you will know this because you will have recognised it, there is an us and them between service users and mental health staff. These people are different from me. These people are not me. These people have got problems. I've not got problems. I'm fine. And that's just rubbish, because many of us have got problems as well. But if we've got problems, then that means we're no different from you. We're not. But a lot of people just simply can't handle that. They can't cope with it.
Is it maybe common practice, common procedure I'd assume it would be, for a psychiatrist to see regularly, just as a matter of procedure, another therapist, another psychiatrist or counsellor? No, not in psychiatric training. If you're going to be a psychotherapist, yes. So in psychotherapy training, and some psychiatrists are trained as psychotherapists, and I did some psychotherapy training, but psychologists don't have to either, not unless you are training in certain types of psychotherapy. So a clinical psychologist doesn't have personal therapy, psychiatrists don't have personal therapy. And it's very much treated as being a medical specialty, and you don't, unless you are training as a medical psychotherapist, then you won't have your own therapy. But it is the same in psychology as well. But I'd assume that, if it's, psychotherapists coming at it from the cognitive perspective maybe, and the therapeutic perspective, psychiatrists are coming at it from more of a biological and medical perspective. But regardless of that, you're still both hearing, spending your days listening to personal accounts of human misery.
Yeah, absolutely.
But it just seems like common sense that would be a thing. Would be helpful.
Yeah. During training, one of the things that certainly happens is that I attended, and trainees attend, groups where they talk about their emotional reactions to the job and how they're coping, and they have an opportunity. That's part of their training, is to do that, to try and help with their self-awareness. And I mean, GPs can attend similar groups as well. But when you are qualified, you don't have that kind of access anymore unless you do it voluntarily. And I've always thought that that even if you're a qualified mental health professional, you should have a regular opportunity to be able to reflect and to talk about how you're coping with the job and about your concerns. And because it's very stressful, listening to people and being with people, there's a lot of emotional work that you do during the course of the day. And people obviously cope with that in different ways. Some of them aren't always very healthy.
Yeah, you see, because I mean, I've spoken about this on the podcast before. People, regular listeners will know about my history, but I spent a lot of time over the past, between being like 20 and 30 years old, in different guises working around the sex industry. Not in the sex industry, but I worked as a chaperone for girls that were escorting and things like that. And just from doing that, a lot of that was you, by nature of that job, especially when you start in the sort of the lower realms of it. I heard a lot of stories, I saw a lot of things, and just having those conversations just made me miserable. And I know from that just how much hearing other people's stories can have an effect on you. And I mean, that definitely affected my mood. But what's even more difficult, I guess, from your perspective, is I'm just sat there listening and being a shoulder to cry on or whatever, or just a friend. We're in this shit situation together, and we just try and talk about it. But for a practicing psychiatrist, you're not just listening to these people. It's your responsibility to help this person out. But you don't just bear the responsibility of one person. It's however many people you see during the week. I mean, I remember one of my favorite quotes ever from this podcast was from the first episode I ever did with Professor Chris Dowrick from Liverpool University, and he said that his job as a doctor was to hold, when it comes to depression, his job was to hold on to somebody else's hope until he can give it back to them. I thought it was a brilliant quote. But then the burden of that just seems like a really difficult thing to deal with. So I'm interested now in whether, when you said that, there's been times when you've had to come out of work because, do you mean maybe from an emotional and an ethical standpoint, you wasn't able to provide a service? I'm wondering, have you ever had to come away from work and had a depressive episode as a direct result of being a psychiatrist and not necessarily from other things going on in life?
No, I can honestly say I haven't. I absolutely agree with what Chris Dowrick said. I think that one of the things that I've had to do in my career is to carry that hope for people, and sometimes for many years. And that's been something that can feel like a burden, but it can also feel like a very fulfilling thing to do when you see people actually begin to recover and start to move on. One of the really great things for me has been seeing people over time and seeing how they can change. But the things that kept me awake as a psychiatrist weren't my patients. I had a sense that I think I was giving them as much as I could and doing as much as I could. My responsibility, I did have a responsibility, and that was to be up to date, to be able to do the right things, to be able to do things that were based in evidence, but also to care and worry about them, which is what I did. But the things that triggered my episodes off were often just to do with work and to do with some things to do with family, but some things to do with just the pressure of working in the NHS. I used to joke, it was never my patients that kept me awake. It was the latest conversation with a manager. And it was often that I found hard. I worried about my patients, but they didn't make me depressed. Very often, and I'm sure a lot of doctors will tell you this, the best part of the job is being with the patients, because then you feel like you're doing something useful. Right. Sometimes it feels like the worst part of the job is having to deal with the rest of the crap that comes with being a professional working in the NHS. Whereas when I was in my office with my patients, I felt, well, at least there, if the rest of the day was going badly, at least there I was actually doing something useful.
Do you mind me asking what it was that tipped you over into feeling like what you were dealing with was a depressive episode? Because, stress at work is, a common thing. I don't mean it's an okay thing, but it's a common thing.
It's very, very common.
Yeah. And, stresses with like family life and stuff. But, some people, the luckier amongst us, would maybe would maybe label these experiences as stressful or as things that are emotional experience, such as sadness. Whereas for something to tip you into a depressive episode where you're actually having to come away from work, especially because I think one of the most popular pieces of advice, and I do think there's something in it, is when you are going through something, maybe a stressful time, or you're a bit down in the dumps or whatever, doing something productive can be a good thing to focus on. But there's that sort of ironic or strange thing when it's depression. There's something qualitatively different about it that makes work and productivity either a bad idea or just you're just sort of unable to do it.
And you just, I think for me, I think you're right. There's a really important difference there between sadness and depression. And depression, the times that I had to take time off work, one of the things that happens is my thinking, and I start to ruminate about things. I start to go over them and over them and over them, trying to work out the solution to something. And that would keep me awake all night. I would be constantly thinking about the same thing, trying to work it out, driving my husband crazy, constantly asking him about it. And he'd say, oh, you're not well, because he would recognize that as being a problem. Not being able to sleep or eat much, losing weight, feeling no joy in life, feeling unable to enjoy the things that I would normally do, just wanting to sleep during the day and be up all night.
See, now that's a perfect sort of example where someone might say to you, you see these things happening, you're well trained, well versed in this stuff, so come on, crack on, let's figure it out, and surely you can be systematic about it and get through it very quickly. But what's been the real experience of that?
The real experience is that because you are conscientious, and that's part of your personality and part of one of the problems that gets you into these situations of working too much anyway, you don't stop. You carry on, and you carry on to a point where you just realise someone says to you at work, you're not coping. And I think the first time I got really unwell at work, which is when I'd been a doctor for about 4 or 5 years, someone else had to say to me, you need some time off. As time went by, I was able to recognise that myself. But you do push yourself. You carry on pushing yourself. And I've seen I've treated a lot of healthcare professionals who push themselves exactly the same way. and they're just driven to keep trying to do it, trying to carry on, trying to put things right. And just as you were saying earlier, just can't stand away from it and kind of get a perspective on themselves. It's really hard to stand away from yourself and look at yourself. It requires someone else very often to do it. And my other half is very well versed in the early warning signs that I'm not very good. And one of them is me constantly asking for reassurance about something that's happened that's upset me. And that can be very, very irritating, because I'll go over the same thing over and over again. And I know that that's kind of like, it's a bit like obsessional thinking, but it's depressive rumination. I just repeat the same things. When I had some cognitive therapy, it was actually an enormous relief because I'd never done much training in cognitive therapy as a psychiatrist. And when I first saw a cognitive therapist, it was lovely because he explained to me, it was absolutely clear that he understood what my thinking was like. And he was the first person that I'd ever really thought, yeah, you do actually, you actually know what's going on in my head. You understand what this horrible rumination's about. And he said, you're trying to solve a problem and you'll never solve it. You keep revisiting it and you'll never solve it. And he gave me some techniques which I found helpful in actually trying to manage that. They don't always work. When I'm very depressed, they don't work. But they're quite good at helping me to fend off that thinking and deal with it. But that was one of those moments where you meet someone that actually you think, yeah, this person actually has got a clue what it's like. I don't know if he'd ever experienced it himself, but he'd certainly talked to lots of people who had. And that was really good.
Yeah, well, I was sort of interested in I am interested in that dynamic and how that plays out because, I sort of guilty of it when I finally got myself a therapist who the dynamic just worked between us. One of the problems with it is he made the subject really interesting for me, and so I started to read up not just on anxiety and agoraphobia, but I started to actually read up on the type of therapy and the sort of philosophical underpinnings of it that he was applying to me. And then a lot of our sessions would sort of devolve into philosophical arguments about, and he'd always try and discourage me from it, but I wasn't having any of it because it became sort of a battleground for ideas. And I'm just wondering if any of that sort of rings true for you, because, even though you said you've maybe no experience in cognitive therapy before, surely there's got to be that sense of, I don't know, just even though you're not trained as a cognitive therapy yourself, you've sat down and heard all these stories before, and it's like, I know what's going on here. And was it maybe a bit of cynicism as well?
I think there's always a bit of cynicism at first. You can't help that. I mean, I'm naturally a bit of a cynical person in that sense, so it takes a while for people to convince me. But when you're quite desperate and you're feeling awful, you're looking for people that will help, and sometimes that cynicism doesn't kick in quite as quickly. Then I understood what he was talking about intellectually, and that was really interesting. But I also felt like he understood what it was like emotionally to feel like that as well. And I think sometimes we can get into one of the things, people sometimes do is they get into intellectual discussions about things as a way of avoiding the emotions. And he didn't let me do that. He was very interested in trying to help me look at how my thoughts and my feelings had an impact on each other.
Yeah, I'm just interested because I think I read an interview that you'd done, and it must have been a while ago now, because I think during that interview you said that you'd never actually received cognitive therapy and that you just received psychodynamic therapy.
I had cognitive therapy must be about 15 years ago now. It was the last type of therapy that I had, maybe 10 years ago. It was the very last therapy I had. I had an awful lot of psychodynamic therapy throughout I saw about 3 different psychodynamic therapists, one of whom I couldn't stand, and I didn't think he could stand me either, so that wasn't going anywhere. 2 others that were helpful. And then it was later, much later, when I finally got referred to a cognitive therapist. And that was the very last kind of therapy that I had. And I haven't had any other therapy since then. I saw him for about a year.
I just know that, you know, with cognitive therapy, it's this, the idea is focusing on present emotions and thoughts that are coming up and figuring out whether or not it's distorted thinking, whether there's a different way of thinking about them. Whereas I believe psychodynamic therapy is sort of focused on like past relationships and childhood a bit more. And I'm wondering sort of what do you think the origins of your depression are? Because it seems like that, you know, if the psychodynamic therapy wasn't working for you, you've moved on to something else. I'm just wondering if that speaks to the nature of your depression.
No, the psychodynamic therapy did work. It worked at the time. It was necessary for what I needed to do at that time. Psychodynamic therapy addresses the fact that the things that happened to us in the past are still affecting us in the present. They're still affecting us emotionally in the present. And I didn't have a particularly happy childhood. I had difficult relationships with both of my parents. And that dynamic was still playing out in my relationships in the present. And I didn't grieve for my father when he died because of that difficulty. And it was absolutely right for me to have psychodynamic therapy when I did, because I needed time to talk about all of that mess and to try and make sense of it and to try and sort it out. And then cognitive therapy I had later, and that was when I was really just trying to come to terms with living my everyday life despite having problems with my mood from time to time. And that was different in that it wasn't about exploring the past. It was trying to understand. One of the things I found most helpful was trying to understand the rules by which I live my life, my rules for living, and the kind of conflicts that they sometimes pull up in you, like wanting to be liked by people, but at the same time having a fairly black and sometimes difficult sense of humour. So those two don't always go together. So it's quite easy to offend people, even though you want people to like you. And I do have that kind of sense of humour. And just understanding that I can't be everything. I can't live my life by very, very rigid rules. Being a perfectionist, which I am. So it was really helpful to understand my thinking patterns at that point. And that helped me much more in everyday life in coping with the problems at work and the stress of, you know, being an academic and getting on with everyday life. By that time, I was much more stable in my life, having sorted out a lot of the stuff from the past. But so I think that my depression was partly caused by things that happened to me early in life. I think genetics play a part as well. Both of my parents were really anxious people. My brother had developed OCD when he was only very young. And I find it kind of hard to understand how I got the way I am without looking at my family history. But there were also things that happened in my family as well that played a big part. My mother, you know, lost her parents when she was young. I didn't have an easy relationship with her. I wasn't the kind of daughter that she wanted. You know, I wasn't the kind of daughter who'd go shopping on a Saturday, get married and live nearby. I was ambitious, you know, and I wanted to do things. And I wasn't her kind of daughter. And I came from a very working class background and went to a school went to grammar school, passed my 11 plus, got to grammar school, and started to grow away from my family and feel quite alien from them. And all of that played a part in me feeling quite anxious as a teenager and needing to get away, but not quite sure what I was getting away from. So I can understand my depression in that sense, but I needed to take tablets as well, and I'm still on them. I've been on them for years. Psychotherapy alone wasn't enough. I wish it had been. I'd have loved it. I'd have loved it if it had been. It would have been marvellous, because at the time, I was a great believer that I wanted to be a psychotherapist, and I thought that everything could be sorted out with talking. And I think talking is absolutely essential, but for me, it wasn't enough. It wasn't enough to stop me going quite seriously down.
Well, yeah, we're gonna get onto medication now. It's the reason I was interested in that history of it, and you said you've had bouts of depression sort of intermittently, and along with bouts of, well, not bouts, but experiences with different psychotherapies. And what I wanted to ask ultimately was, despite the depression keep coming back, that it's recurring, I'm just wondering if over the years and with time and this, all the therapy and the revelations sort of compounding, that I'm just wondering if, despite the depression coming back, has it become less and less severe over time, and do you get better and better at dealing with it?
I get better at dealing with it early because I recognise it coming. But it's varied in severity, often dependent on, what kind of things have triggered it off. I had hoped when I retired from work that it would be easier, but then I had quite a bad episode. There were a lot of life events that just triggered it off. Nothing to do with work. I lost my cat. She died. She got killed. And I don't have kids, and my cats were very important to me. So I lost her. Things happened in my family, with my husband losing his job. Things happened, life events, and they just triggered off another episode that was quite bad. And that was a couple of years ago now. So they varied in intensity. I think the very worst that I was quite a long time ago, about 25 years ago now, and that's when I finally went on antidepressants and stayed on them, because I was really very unwell then. Couldn't get out of bed. I was stuck. I was off work for 6 months.
Well, we might have segued nicely into this bit now, and we're talking about the medication side of it. And what's been interesting as well is, I don't know whether it's just a linguistic thing because of the nature of being a psychiatrist, or whether this is part of your the way you conceptualize depression, but you seem to speak of it in a sort of disembodied sense, and you refer to depression as it. And like I say, that might have roots in the psychiatric perspective, which is the biological side of depression. And that's what I kind of want to talk about now. And so just yesterday, I did an interview with Joanna Moncrief, who is famously a critic of pharmaceutical medications for mental health issues. And I think I read on a recent blog of yours as well, just before we started recording, that you said that you feel like there's a bit of an attack on antidepressants taking place at the moment.
Yeah, well, I think there's a bit of attack on depression, really. I think that I read a lot and I hear a lot about people saying that we're not depressed, we're miserable. Frankly, I don't much like. I know I can be miserable at times, but I think there's a real difference between sadness and depression. And I think some of the people who are coming at it from that perspective just don't get it. They think it's all caused by social causes, and it's all affected by what's going on in our lives. And that somehow we can just climb out of it, or really that, politics need to be addressed and big things need to be done to the world to make it that we don't get depressed. Well, that's fine. But I mean, I don't disagree that big things need to be done to the world. But as a working psychiatrist, my patients couldn't wait until big things were done to the world. I had to do something there and then. And when you're suffering, you want something doing there and then. And that was how I felt. So yeah, I probably do call it because it is like something that descends on me. It doesn't feel like me, although it probably is part of me. When you've been on tablets for a long time, you don't quite know who you are. I don't know whether me is the person. I don't think me is the person who can't get out of bed and feels like ending my life. I don't feel like that's the real me, but I'm not entirely sure the real me is the person who's talking to you now. The real me might well be somewhere in between. But when I've taken medication, that enables me to function. I'm not sedated. It isn't the sedation that gets rid of how I'm feeling, because I can generally get through the day without sleeping. I was able to write all of those papers because I'd taken antidepressants. I wouldn't have been able to write them without them. Because when you can't think, I couldn't get my sentences together to write. I'm generally much more creative, when I'm well.
What would you, I mean, speaking on that,
yeah.
You'll be familiar with, I won't have to explain it now because people are going to listen to Joanna's episode before this one anyway. So if you haven't, tough, because I'm not going into it too much. But you'll be familiar with this idea of a disease-centered model,
yes,
and the drug-centered model.
Yeah,
yeah, and I'm interested in your opinion on that, because I have to confess that I think Joanna puts forth an extremely compelling argument, to the point that, I was skeptical about pharmaceuticals and all that in the first place, but I mean Joanna is like an intellectual sort of leviathan on this topic, and I just find once you've read her accounts of it, it's hard to find your way back from it. But that's just me speaking as a sort of an amateur psychologist or whatever. And I'm just wondering what your opinion of that is, as somebody not only that will have read the literature on it and scrutinised it, but who has got, like say, first-hand experience of taking these drugs.
Well, I'm not a psychopharmacologist. I'd be the absolute first person to say that. I think that we put too much emphasis on there being one thing called depression. I don't believe there's a disease called depression. I think it's a term that we use for a state that people get into. And I think that state differs between people, so that there's many, many different forms of it, many different varieties of experience, many different causes. So that for some people, I think the biological part plays quite a big part. It doesn't take much to trigger them off getting into that state. For other people, I think the biological plays a very small part. And it probably is largely related to what's going on in their lives and the things that they've experienced and the way that they're thinking. And so I think she has a good argument about the difference between there being a drug-centered and a disease-centered. I would agree. But I do think that I wouldn't dismiss I certainly would not want to dismiss the fact that there is evidence that things do go on in our brains, that our brains are part of our body. And that for some of us, I think what happens in the brain may be more important than for others. There's enormous variation. So I think to make it all a very black and white, all or nothing thing, is too simplistic. I do think that, I mean, I've seen many people with, say, depression caused by physical illness, depression caused by coming along and being depressed and then discovered that they've actually got an underactive thyroid gland, coming along and being depressed and discovering it's because they're on steroid medication. Our brain and our body are just so connected. So for some people, I think disease processes, whatever they are, and I think we still don't understand them. People like, Carmine Parianti, who you had on not so long ago, are beginning to understand it, but we've got a hell of a long way to go. But there are other people out there for whom brain processes will play a very, very small part. So I kind of feel that simplistic approach to saying it's definitely not brain, absolutely mustn't be. No way does the brain play a part in our mental state. I just find that really, I can't accept that, because I just think that we're all unique, and some of us we have to differing degrees and at differing points in our lives. I know that from when I did old age psychiatry, that as people get older and they start to have problems with their brains start to age, it seems to take much less to tip them into depression than it does when their brains are younger. And that's almost certainly due to biological aging of the brain. So things vary during our lives. And I personally, when I've read what Joanna's written about medication, I know where she's coming from, and I think I was probably once there myself. But when I've taken the things, and after 2 to 3 weeks, you suddenly wake up and you suddenly notice that the birds are singing, and you haven't really noticed that the birds are singing for some time, and you suddenly notice the grass and the flowers in the garden, and you start to notice the world again, and you start to have those kind of moments of joy again in your life. I can't accept that that's just because I'm sedated, or it just doesn't make sense to me.
What about the other angle of it, or the other contributive factor, I think Joanna would argue, would be the idea of it being possibly an active placebo.
Well,
and but would that be? I mean, even if it was, would that be such a bad thing as well? I mean, but again, I don't know what you think about that.
Yeah, well, if it were an active placebo, I think it would work a bit sooner. I think it would work as soon as I started taking it, because I'd start to feel better. That hasn't always been the case, and sometimes tablets haven't worked, and sometimes they've made me feel worse. I can't accept that it's all about placebo, because that isn't how it's personally felt to me, and that isn't what I've perceived in my clinical work with patients. It doesn't fit. I mean, I'm not an expert on, as I said, I'm not a psychopharmacologist. I'm not an expert on the science of placebos. But my understanding of a placebo is that if you think it's better, then you'll start to, if it's going to get you better, it'll start to make you feel better. Well, antidepressants certainly don't work immediately like that. They take a while to work. We don't really know why they take a while to work. For me, they've always taken, when my medication has changed, they've taken longer to work. The only one that worked faster was when I had to go on lithium, when I was not responding to medication. Many, many years ago, I was on paroxetine, and that alone didn't work. And even an increased dose didn't work. If it was placebo, you would have expected that it would have worked. And then lithium was added, and about 50% of people who are not responding to antidepressants, if you add in lithium, it does improve their mood. And it worked for me. And I actually carried on using it. I used it clinically with a number of people over the years, and it worked. it's not a great drug to be on. It's pretty horrible, but it was better than feeling the way that I was feeling. It got me better.
What would your sort of what's your go-to theory on what antidepressants are actually doing then? Because, I think it's fair to say that the evidence is pretty sparse. The idea of it correcting a chemical imbalance, I think the only people left sort of propagating that view is maybe the media and the public. I think even very few psychiatrists had subscribed to that. Carmina, during the debate, said that there's a hypothesis that it's got something to do with neurogenesis. I don't know, what's your
I
take
don't
on
have
it
a ghost theory.
You
I'm a pragmatic psychiatrist, and I think they obviously do something to your brain, as do a large number of drugs that people take. I don't quite know what it is that they do, and I don't understand why it takes a while for them to do it, but they certainly do something. I still don't think we understand it. For a long time, people were very enthusiastic about the neurotransmitter theory. I remember feeling, gosh, does that mean there's an answer? Does that mean we understand it? And then we had the SSRIs, and it was all very convenient that we had the serotonin hypothesis, and then we had the promotion of the SSRIs. And yes, a lot of drug companies did very well out of that. And, those theories get pushed at various times. But I just don't know. I read certain things about depression every time I open the newspaper. Sometimes it feels like there's a new theory about what causes depression. The latest is inflammation. And that's very interesting. But as I say, that may be true for a small number of people. That is not the answer. There is never going to be a biological answer for depression on its own, ever.
I suppose that maybe the one trickiest question to answer for you personally might be, as somebody that's sort of in favour of antidepressants and says, well, they work for me, is if they have worked for you, then why the recurrent episodes of depression, and why have to take it for so long?
Because they don't work for everybody, and they don't work fully for everybody. And I think what they've done is probably made my episodes less severe, at times anyway. My psychiatrist thinks that I might have been in hospital at some point had I not been taking them, and I think he may well be right. But I've had breakthrough episodes of depression. I've had times when the antidepressants seem to stop working, and I think there's some evidence that may happen. That certainly I was on an SSRI for a long time, and then it seemed to stop working. It no longer had an effect, and then I had to withdraw from it, and that was an unpleasant experience. I'm quite convinced about withdrawal symptoms. So I think that they do. I don't think that they are as good as many people would like to think they are. We know there's a lot of people they don't work for, and they don't work fully for a lot of people. I used to see many people for whom antidepressants would help them to get to a point where they could start to do those things that you were talking about that help you to feel better. But they are never an answer on their own. You've still got to go and sort out some of the problems that are causing you to get depressed in the first place. You've still got to sort those things out. What they do is they give you the energy and the ability to concentrate again, and a bit of the positivity back so that you can start to sort things out.
Well, that's a good segue to my next question, Linda, which is, regardless of the antidepressants and whether it's placebo or whatever, that when you get to that stage where you do feel like you're getting your energy back and a bit of get up and go, and you can actually roll out of bed and do something with your day, what is your protocol? What are the things you do? What are the things that you find help you get back to some level of normality?
Trying to get back into a routine.
Mm-hmm.
Because when you get really down, you lose your routine. So for me, one of the most important things when I'm like that is just to try and get out of bed, first of all, at a reasonable hour and not stay in bed. And then just trying to get my daily routine back and just trying to get back into eating regularly, taking a walk, doing things that I have stopped doing, doing things that I used to find pleasurable when I felt better. And even if I don't feel like doing them, trying to push myself to do them. Because in the doing of them, as you said earlier, you actually start to feel better. And for some people, that on its own is enough without taking antidepressants. But even if you take antidepressants like I've done, when you get down, you still have to kind of start yourself off doing those things. And I find that part of staying well for me is having that routine, a kind of healthy living routine. It's really hard to stick to it. I mean, you know, alcohol. I love alcohol, but I know that if I drink too much, it really affects my mood the next day. For me, one of the key things for keeping my mood stable is sleep, and alcohol disturbs my sleep. So if I drink too much, or I eat too much, then I won't sleep, and the next day I'll feel awful. And so I have to kind of live this. And I used to talk this through with my patients. I used to talk through, what are the things you've noticed that help you to not get depressed? And I have to do the same thing for myself. And it's not easy. It really is quite boring living a routine existence. And sometimes you just go off the rails, and it's worth it, you know, even if you feel rough the next day. But that's what I have to do. Exercise. I have to take some exercise, and that's hard when you're feeling really down. Because if you can't get out of bed, you can't go for a walk.
Yeah, I was going to say, what does your exercise consist of? Because people hear exercise and they think exercise bike or one of those sort of annoying cardio routines. But
yeah,
what is it for you? Just walking?
Walking. I've got a rowing machine. When I can force myself, I get onto that. I find exercising really boring. I think all the people who talk about exercise being great for you were all the people who did well in sports at school. They have no problem doing it. I am bored to death by it, but I managed to force myself. If I force myself to get upstairs in the morning and do 10 minutes of exercise, then I feel better for that. I'm going for a walk, walking uphill, walking up hills.
Yeah, I've got to say, Linda, I'm not a fan of the idea of sort of going exercise, even if you're not in the mood for it. I just because I don't think it's sustainable, you know, when you're doing it and you hate it. Whereas absolutely. I think walking's always a bit of a winner, isn't it? I mean, unless you're agoraphobic like I was, it gets a bit tricky then. But yeah, I think walking's always a winner. Is another question I've got? It's so in another one of your interviews. You said that
is coming back to haunt me.
Well, in a good way, this one, I think. And it's an interesting question. It's one that I've not really posed to anyone before as well. It's that you said that more important, something that's helped you more than antidepressants or therapy has been love, your relationship with your husband, which on the face of it could sound quite trite, I suppose. But the question that sort of arises out of that, and I think it's an important one, is, you know, often the experience for people, the experience for my partner was she didn't know what how to cope with me, how to deal with me when I was in my dark place. And so, you know, it's not going to be universal, but I'm just wondering, what are the things that your husband does or did for you that you found that were just helpful to you when you're going through that process? You know, maybe it's just as, like I say, it's not going to be universal, but just sort of, you know, a little bit of advice for those people listening that they're not depressed, but they're dealing with somebody that maybe is, and they don't know what to do.
Number one, not telling people to pull themselves together. Not offering advice and telling people, if you just do this, you'll feel fine. Listening, being prepared to listen, to talk over problems, and not avoid them. Suggesting you get out for a walk together, and not forcing you to talk while you're walking, but the opportunity's there when we spend time together. Don't have to talk, but then there are times to talk. Physically taking care of me when I've not been up to doing it myself is really important, because there's been times when I've not been able to do that, and just being there and taking care of me. Being incredibly patient. Patience is not just a virtue, it's essential if you're living with someone who gets depressed. I think for me, why, and I hated the headline in that article because it was a bit trite, but I think it is about when you've had kind of messy things going on in your early life. I do think, and there's evidence for this from child psychiatry, I do think that if you have a good relationship later in life, that can actually be healing. It can help you to come to terms with a lot of those issues that you didn't sort out earlier in life. And I've seen that in my patients. People who've had difficult childhoods can be rescued by a good relationship later in life. And I think that's one of the things that's been really important for me.
Well, you know what? Kind of on that note as well. This is something I've wanted to do an episode on, but it's about finding the right person to discuss it. So we just talked then about the things that your husband did or does for you that help you through it, and like you just said, then being in a strong and stable relationship. Oh God, sounds a bit Theresa May, that, doesn't it? A strong and stable relationship, it is important. But speaking from personal experience, what you can inadvertently do when you're going through a bad period is destroy your relationships and push people away from you. And so I'm just wondering what you think, and maybe not just from personal experience, but from clients that you've spoke to. What do you think? Because this is something I still haven't formulated properly to talk about yet, but I'm just wondering what you think are a person's responsibilities when you're going through depression. What are your responsibilities to the people around you? Because I don't think it's the right approach to just lean on other people and hope to be looked after. That certainly didn't work out for me. But I'm just wondering what you think about that.
No, I don't think it's about leaning on people. I think you have a responsibility to try and work at getting better. I do think that. Otherwise, you will become a person who doesn't want, who appears like they're not wanting to move forward. So it's about getting help, not refusing to go and get help, getting help, not using your partner as a therapist, but going and seeing someone separately, listening to them. You can't use your partner as a therapist. That's just not possible. Doing the things that it is suggested to you might be helpful in your recovery, because you have got some responsibility to work at your own recovery. Otherwise, you're just going to say, "Well, I just want to stay in this position, and I'm quite happy. Just take care of me for life." And that is not going to keep you in a relationship. Not making decisions. Sometimes I've seen people wanting to make really kind of often quite rash decisions based on how they've been feeling about important things in life that will affect their partner, and not making those decisions, not just rushing off and doing that until they feel a bit better.
Right.
Because you can do some really damaging things that will affect your relationship, like giving up work or something like that. And, your partner may be the person who's looking after the kids, who's doing everything. and thinking, why the hell are they doing that? That's going to affect me. But it is difficult, because I think that when you're depressed, you can be so self-centered.
Yeah.
Be focused on yourself and not actually think you can't think what's going on with people around you. And
it's a topic that I don't see sort of talked about very often. I suppose it's a bit of an uncomfortable one, but in the situation I found myself in, I just sort of tore my family apart. And at first it was like, how can they not understand I'm going through this, that, and the other? But then you take a step back and it's like, no, you did this. Do you know what I mean? You do have to bear some of the responsibility for that. And I think it's a really interesting subject. I do want to explore that one a bit more. Okay, final question, Linda, before we jump into the quickfire questions, is now that you're a retired psychiatrist, I'm just wondering, sort of looking backwards over it all now, how would you summarize your career and your experience and what it's meant to you, and maybe where you think where you'd like to see psychiatry go next, now that you've contributed to it and stepped outside of it?
Gosh, that's a really big question. I think the things that I think my work as a clinician, the things I did with my patients, were probably the most useful thing I did. I know that I was an academic as well, and I was a teacher, but I can't help feeling that what I did when I was actually with my patients was probably the most important part of my career. That's the bit that I remember most clearly, and I miss. But I couldn't carry on doing it because I was exhausted and I was ready to stop. And I was got physical health problems now as well. So I had to stop. But yeah, I mean, I'm really pleased I really am so pleased I had the opportunity to do that in my life, because I think I helped people. I think I must have kept some people alive. Quite a few probably, but that's part of the problem in psychiatry. You don't necessarily find out, but
yeah,
it was a joy to me to be able to do that, and a great honour to be able to work with people. I would like to see much more joined up research in psychiatry. I am so fed up with psychologists coming back with a great psychological theory that's the answer to everything. And everyone saying, oh, it's all about social things. And then someone else saying, oh, it's all about inflammation in the brain. I think we need far more joined up thinking in mental health. We need people working on problems because they are interested in mental health, not because they're coming to promote their particular profession. Mm-hmm. I mean, as you probably, gathered, I wasn't a biological psychiatrist. I was much more of a social and psychological psychiatrist in my training, even though I used some biological treatments. But I do think it's about acknowledging that it's far, far more complex than any of us like to think when we're coming at it with our simplistic theory that's going to answer everything. And people are so incredibly different that we'll never have one answer for depression or one answer for schizophrenia. I don't think there's a single schizophrenia. I don't believe in that. I think there's a wide range of different ways in which people present with something that we call depression, but it's got lots and lots of causes. And I think we should start. I'm really pleased that I saw that I think the Wellcome Centre, who fund research, have started to look at funding much more kind of joined up research in mental health, and I'm really pleased about that. We've got to get away from this single issue research.
Right, okay, Linda. Before we jump into the quickfire questions now, this is your chance to do a bit of plugging away. So if you could give all the listeners your links to, I mean, you mentioned a couple of organisations at the beginning. What were they? Storm and 6 Degrees.
Well, 6 Degrees is an organisation in Salford that provides psychological therapy to people of Salford. Anyone in Salford who's referred with a mental health problem, a common mental health problem, anxiety, depression, they get referred by their GP, or they can self-refer to 6 Degrees. So they're easy to find for people living in Salford. Storm is about suicide skills prevention training, where we've spent years trying to help health professionals how to talk with people who are feeling that life isn't worth living, feeling in crisis. And I think it's all about talking. And listening. So we try and train professionals to do that more effectively.
And a bit of shameless self-promotion. So websites, social media, any of those?
Website, lindaGask.com, all one word.
Nice and easy.
Social media, I'm Susie Puss on Twitter, which causes hilarity to some people, but that was the name of my cat. And she was my alter ego, so I'm easy to find. I'm quite active on Twitter. Ever since I retired, I've loved keeping in touch with the world on Twitter. Okay, and the book, which is the book is, The Other Side of Silence, a psychiatrist's memoir of depression. It came out 3 years ago. I've been working on a follow-up, which is going to be about the whole process of what recovery is all about. Ah, interesting. And that's in process. Okay. So, do we know when that's going to be out? No. No idea. No idea. Right. Well, as usual, I will include links to all those in the show notes, including the books as well. And if I remember, Linda, and it comes to my attention when the other book comes out, I'll stick that in a bit later on as well. Or maybe you can come back on and talk about it. Be even better. Right. Okay. Quickfire questions. So, as usual, these are, you get the first one free, but after that, it's just for subscribers, people who are supporting the podcast. You can do that by going to either myownworstenemy.org/support or patreon.com/myownworstenemy. On Patreon, you get loads of extra little benefits as well, so I recommend the latter. Okay, Linda. So, first one is, what is the last book you read, the best book you've ever read, and a book recommendation on this topic, if you will? On this topic? Yeah. Oh, good heavens. That's really hard. The last book I read was a memoir by Henry Marsh called Admissions. And it's not directly on this topic, but it was... Oh, no, they don't all have to be on this topic. Your last book you read can be any book, and the best book you've ever read can be any book. Right. Last book I read, Henry Marsh, Admissions. That was my last book. Best book I've ever read, that's really impossible. I've got loads and loads of books. I'm clearing out my library at the moment. What's the first one that springs to mind? Just gut instinct. Gut instinct would be Middlemarch, which I read as a teenager. And that's where the title of my book came from. The Other Side of Silence. Ah, right. Okay. Both on the inside of it. And the a book recommendation on this topic, not specifically psychiatry, but just anything psychology or mental health related. A book recommendation. I'm struggling here. I'm really struggling. I've got one. The Other Side of Silence, a psychiatrist's memoir of depression. Well, you can I'm very happy to recommend that. Well, you know what? Even though I suppose you guys might have some sort of conceptual disagreements, when I spoke to Joanna yesterday, she said she'd read your book and absolutely loved it, thought it was brilliant. So, right, Linda. That's very nice of her to say that. No, she did genuinely say that. Yeah. So, okay, let's start. So we've got 50. Don't worry, I'm not going to ask you all 50. We've got 50 random questions. Just going to pick some out for about 10 minutes and see what we can do. I should have been prepared with my book recommendation, shouldn't I? I'm looking on the bookshelf. Let me recommend Paul Gilbert's The Compassionate Mind.
Paul Gilbert's been recommended to me I think it's Paul Gilbert's been recommended to me to reach out to get him on the podcast. Is he developed some sort of compassion-based therapy or something?
Compassion-based therapy, but I do find the way he describes his model for understanding how we get depressed and anxious and angry in life, I found that really helpful. Okay. So I would recommend The Compassionate Mind.
Right, well, you know what? Now you said that, because it's been mentioned a couple of times, but that'll be the catalyst for me. I'll drop him if I can. I'll try and drop him an email as soon as I get off this call with you. So,
okay.
Right. Okay. So, first one is: can you remember a time in your life when you felt the most alive?
Yes. When I spent a year living in the US.
Okay, folks, if you enjoyed this episode, or you're enjoying this podcast in general and you'd like to help support it, this is just a quick message to let you know that you can now join our little exclusive members-only community over at Patreon, where for as little as $2 a month, you can gain access to exclusive content like the Quickfire Questions portion from my interviews and my AMA or Ask Me Anything episodes. There's also a members-only newsletter where I give you a little sneak peek into what kind of guests and content to expect over the coming weeks. You can help me steer the ship a little bit by telling me the kind of content you'd like me to produce, and there's also the opportunity to join a private Facebook group where you can interact directly with myself and fellow patrons to share tips and advice and support one another on your own mental health recovery journeys. So if this sounds like a community you'd like to be a part of, please go to patreon.com/myownworstenemy and sign up for as little as $2 a month, which, let's face it, is less than the price of a coffee, and not even one of them like fancy double Belgian chocolate latte bollocks. It's probably cheaper than like a plain old shitty Nescafe from the office vending machine, and it won't give you the jitters or make your breath smell of arse, so bargain. Alternatively, for those of you who do want to help support the podcast, but you can't be arsed with all the extra bells and whistles, you can make a standard one-time or monthly donation by going to our support page at myownworstenemy.org/support. And that's about it. So, as always, thank you for listening, and I'll see you again next time.